And so now on our journey around the world, we're going to head from Ireland for an extended visit in the United States. And our next speaker, when somebody came up with the phrase, the man, the myth, the legend, surely they were talking about Dr. Stephen Liu. He has become the de facto MC of all things lung cancer, whether it be through his rather prolific X or Twitter profile, where regardless of the hour of the day, you can find something important that he's posted, or in his role as a co-host of ISLC's Lung Cancer Considered podcast. He is the resource that we all go to see what the latest breaking, exciting development in lung cancer is. I mean, the hair, the voice, if this whole lung cancer thing doesn't work out for him, I think he has a very bright future as a game show host. And I saw him serve in that capacity at the recent World Conference on Lung Cancer in San Diego, where he served as a game show host for a Jeopardy-style quiz show between leading lung cancer experts to see if they knew their biomarkers. It was entertaining and educational at the same time. But on a more serious note, now we're going to shift gears and talk about small cell lung cancer. And this is a space that historically has been much more difficult. It's a hard beast to tackle, and historically has been considered a refractory disease, meaning we just simply didn't have many options to throw at it. But that's beginning to change as we see new treatment modalities come online, the move toward actionable biomarkers for small cell, which is an active area of research by multiple investigators. And so we're thrilled to have lung cancer's MC, Dr. Stephen Liu, with us today. He's going to be sharing his expertise on the latest approaches for targeting small cell lung cancer. Dr. Liu, welcome.
Well, thank you, Amy, for a very kind introduction. It's a privilege to be here, and really enjoy talking about this topic, in part because of what you said, Amy. This field has changed, and for many decades, we were very stagnant. We're starting to see a lot of hope at the end of the tunnel, and I'm very excited about what's coming next in this next chapter for small cell lung cancer. So we'll talk about some of the new treatment options and how we have made actual measurable progress. Here are my disclosures. Wanted to start with a case. This was a patient of mine, 64-year-old female. She had extensive stage small cell lung cancer. She was diagnosed. Her primary tumor was the right upper lobe of the lung, and unfortunately her disease had already spread to the liver, to the bone, to the brain. Here are some images from her PET scans and an MRI of the brain. She was pretty sick when she'd started. We gave her a diagnosis, and when you look up small cell lung cancer, I think that what's available out there is fairly grim. We immediately started her on treatment with chemotherapy and immunotherapy. And so she received carboplatin, etoposide, and atezolizumab, and she felt better very quickly. Now that part is pretty common. The paradox of small cell lung cancer is we can get that initial response even more frequently than we can with other types of lung cancer. And here we see a response where that tumor on the left side of the screen, which is the right lung, really had shrunk down. Getting that initial response has always been easy. For decades, we've been able to get a response with chemotherapy. But just as predictable as responses, relapse comes a few months later. The respite from chemotherapy is painfully short. And what's important about these two scans here is the dates, which I've uncovered here. When you look on the left, that was 2019. When we look at the right, that was a few months ago. So this is 5 years later. And so while we had that initial response, what's important for her is that she still has an ongoing response 5 years later. Now, I'd love to say that we only gave her one treatment and it's worked for the past 5 years. That hasn't been the case. We've actually had to go through a couple different treatments to get to where we are today, but she's doing very well. And I think it's a testament to the research and the progress that we're seeing with small cell lung cancer. It's largely been ignored by the research community, but we're seeing major advances. Small cell lung cancer accounts for about 13% of all lung cancer diagnoses in the US, but a huge geographic variation. It's tightly linked with exposure to tobacco, though there is a contingent of small cell lung cancer in people that have never smoked, which we're still trying to understand. As a result, you'll see a little more frequently small cell lung cancer in certain parts of the country, the Midwest, the Southeast, maybe a little bit less on the West Coast. This presents as a central tumor. It grows fairly quickly, so patients generally report symptoms over a few months, and it is programmed for quick spread. Involvement of the brain is very common at diagnosis and through the course of the disease. We've had pretty stagnant care over the past few decades because, in part, the initial therapy works pretty well. The chemotherapy we use for small cell lung cancer was pioneered in the 1980s. And when we give chemotherapy like cisplatin and etoposide, we see pretty high likelihood of response. When someone comes in symptomatic from small cell lung cancer, I know that if we deliver pretty straightforward, direct chemotherapy, that we are very likely to improve those symptoms. People feel better generally pretty quickly. 10% of people will have a complete response to chemotherapy. Response is very likely, but the responses are transient. What's shown here is a Kaplan-Meier curve showing progression-free survival. What this means is by 18 months, nearly all patients have already seen their cancer come back. The median time to progression is 4 months, and that's from the start of chemotherapy, which tells us that the majority of patients with small cell lung cancer will respond to chemotherapy, but their cancer will grow back either during or shortly after chemotherapy. Survival had been linked to about 9 months, and that was the case for many decades. When we think of how we could improve treatment, we know chemotherapy plays an important role. We stop sort of this aggressive natural history of the cancer, and while chemotherapy has side effects, generally people feel better with chemotherapy, but the challenge has been the transient nature of those responses. And what we want is a benefit that will last. What we want is something durable, and that's evaded us for a long time, but we got very excited about immunotherapy. When immunotherapy was first developed, it was in tumors like melanoma, where we saw high rates of mutations. And when we think of high rates of mutations at the genetic level, small cell lung cancer is among the highest. So we had very high expectations for small cell lung cancer when we first started its development. I would say now, after having gone past the past decade, immunotherapy does play a role in this disease, but it is a little more modest than we had anticipated. The first study to really show benefit to immunotherapy, to show an improvement in survival, was Empower 133. Now, this was a study that I had the privilege of writing with Dr. Leora Horn at the time. This was about 10 years ago when we first started writing this story. In this study, patients with small cell lung cancer all received standard chemotherapy, and then they were randomized to receive combination immunotherapy at the same time as chemotherapy, and then after chemotherapy was completed, to continue the immunotherapy. That was a straight randomization. Half the people received immunotherapy, half didn't. And what we saw is that the addition of immunotherapy improved progression-free survival, delayed the cancer growth by a modest amount, but importantly, it improved overall survival. And we see the median survival go from 10.3 months to 12.3 months. We see a hazard ratio of 0.76. This was the first study to improve overall survival in small cell lung cancer in almost 40 years, establishing a new standard of care. Importantly, when we added immunotherapy, we did not significantly increase toxicity. For example, if we look at delivery of chemotherapy, it was the same in both arms. Giving the immunotherapy didn't interfere with our ability to deliver the chemotherapy portion as well. We also collected quality of life surveys through, and we saw that with immunotherapy, in this case, atezolizumab, we saw meaningful improvements in symptoms faster, and they lasted longer with immunotherapy. This was approved by the FDA in 2019, approved by the EMA as well, and now it's approved in over 100 countries and is a Category 1 preferred option. This is the first advance to impact survival in about 40 years, and it's reinforced by multiple randomized trials. We waited 40 years to get the first improvement in survival. We waited one more year to get the second. That was the Caspian study. A little bit of a different design. There are 3 arms in this study. The inclusion criteria were a little bit different. It was an open label study. But despite all these slight differences, the outcomes were very similar. When we add durvalumab to chemotherapy, we improve survival, generally to the same degree. Here, the hazard ratio is 0.75. There have since been multiple randomized studies showing similar benefit. When we add immunotherapy, a PD-1 or a PD-L1 inhibitor, kind of regardless of which one, we see a modest but significant improvement in overall survival. And this represents our current standard of care. So are we achieving long-term survival is the question. Are we seeing just transient benefits? And now that these studies have matured a bit, we see that we are achieving long-term survival for a subset of patients. The Caspian study with durvalumab showed that at 3 years, our survival rate was 18%. I know we want that number to be very close to 100, but in the control arm there, it's about 6%. And we know that it would be lower if those patients didn't receive other immunotherapy agents. So an 18% survival at 3 years is an advance. It's not nearly as high as we want it to be, or it should be. And we're working on further improving that, but this is progress. We also have longer survival for the Empower 133 study. When that study stopped its follow-up, the extension study, where patients could continue atezolizumab and observation, was called the Umbrella A study. And there we have 5-year survival rates. At 5 years, the survival rate was 12%. If you break that down year by year, with placebo, with only chemotherapy, we see 39% of patients alive at a year. With the addition of immunotherapy, that number goes up to 52%. And we do see some drop over time, but at 4 years, 13%, at 5 years, 12%, really has leveled off. At 5 years, 12% of patients alive with the use of immunotherapy. This has been validated in real-world studies as well. This is the Maurice trial of carboplatin, etoposide, and atezolizumab. The 1-year survival rate really the same as we saw in other studies. The IMfirst trial, which was done in Spain, the same regimen, carboplatin, etoposide, and atezolizumab. Again, long-term survival being seen in these real-world studies as well. And so how do we describe the benefit of immunotherapy? What is immunotherapy doing here? Well, what I say is it's improving the median survival, improving the hazard ratio. And it's not really how I look at it. While the median does move from 10.3 to 12.3, not all patients derive the same benefit. So in this type of intervention, with the use of immunotherapy, it's not that everyone does a little bit better. It's that a small subset of patients do a lot better. In this case, 12% of patients still alive at 5 years, many of whom not receiving any further therapy. That subset is deriving the maximum benefit. And so it's not that everyone derives a 2-month benefit. It's that some people receive a substantial long-term survival benefit. So it's important to deliver this immunotherapy early. We want to give everyone the opportunity to be in that 12% that's alive at 5 years. And when we wait to deliver treatments later, sometimes we miss out on the opportunity to give them. If we look at second-line treatment, this was from a hospital in Germany. All the patients that receive frontline treatment, only half of the people get any second-line therapy, and only 22% receive any third-line therapy. So if we start with just chemotherapy, and I promise someone that we're going to give immunotherapy the minute the cancer grows, that is not a promise I can keep. Because sometimes when cancers come back, they do so violently, and we're no longer a candidate for any other therapy. Progression can be devastating. With small cell lung cancer, the best opportunity for impact really is in that frontline space. Immunotherapy was studied in the second-line space, and the outcomes were not very good. Checkmate 331 looked at an immunotherapy agent called nivolumab, and compared to chemotherapy, there was no difference in survival when we used it as treatment number 2, and the progression-free survival was actually much better with chemotherapy. We even looked at the maintenance setting before the cancer grew, but after chemotherapy was done, and we simply didn't see the benefit. In this case, nivolumab plus ipilimumab did no better than placebo. The benefit is when we give immunotherapy upfront early. And that's really what we advise for all physicians, for all patients. Frontline treatment with chemotherapy, we want to deliver immunotherapy early to get that benefit. And we know a subset of patients is driving most of that benefit. And the real question we have is, who are those patients? Do we have any predictive biomarkers to guide that? And unfortunately, we don't. We need to give the treatment early. We simply can't identify who those patients are. We've tried. We've looked at all the obvious things, and they're not really shedding any light on the subject. If I could identify who is going to be in that 12% with just chemoimmunotherapy, I can make sure they receive that. And we can explore other strategies for the other 88% of patients. We simply don't have any biomarkers in that setting. There is some work being done. This is looking at expression of certain transcriptional regulators. And so at the RNA level, if we look at the genome, the genomics of the cancer, we can cluster them based on expression of certain transcriptional regulators. And this categorizes small cell lung cancer into different subsets. This is not quite ready to be used in regular practice, but this is just to illustrate that we're finally starting to appreciate some differences at a genomic level, at a scientific level, at a biomarker level. These are differences that we see in clinic. I know they exist. When someone is receiving chemotherapy for small cell lung cancer, I'm fairly confident they're going to feel better with the chemotherapy. I'm fairly confident the chemotherapy will work. But I'm also confident those cancers will come back. And when they come back, some of them won't respond to any treatment at all. Some will respond to lots of treatments for various amount of time. So there are differences that I see in the clinic. I just don't know up front which group we're going to be in. These biomarkers might be a clue towards that, but they're not ready yet. One of the challenges is that tumors can move back and forth between these different subsets, which makes it very challenging. But if we look at certain subsets, look at the far right on this figure. In light green, we see patients that have survived for a long time, these long-term survivors. Notice that there's more green. There are more long-term survivors in this SCLC-I group. This is a group of biomarkers with an inflamed phenotype, and it's true, there do seem to be more long-term survivors when we see this cluster of biomarkers. But we also notice is we see some long-term survivors in all of the groups, which tells us that we can't use this to prevent or to avoid giving someone immunotherapy. Right now, everyone receives standard immunotherapy until we understand these biomarkers a little bit better. An interesting thing about small cell lung cancer is that it is exquisitely sensitive to radiation therapy. There are several studies looking at the role of radiation. I think these are important to talk about. First has to do with prophylactic cranial radiation. And very early on in the 1950s and 60s, we would see that when we gave chemotherapy to patients with small cell lung cancer, while it would work very well in the body, we would often see cancer emerge in the brain. And the brain ended up being what we call a reservoir site, a site where these cancer cells can hide. It's important to look for those at the beginning, but they came up with the idea of delivering low doses of radiation to the brain to try to kill any microscopic cancer that's there and prevent the cancer from coming back. This was studied in many small trials. Ultimately, there was a large study done in Europe led by Dr. Ben Splotman that looked at prophylactic cranial irradiation, typically about 2 weeks of low-dose radiation to the brain versus just observation. What they showed is that when they gave prophylactic cranial irradiation, they reduced the risk of spread to the brain. The 1-year risk of brain metastases went from 40% down to 15%. That also improved survival. Now, it's only a 1-month improvement in overall survival, but it doubled the survival at 1 year. These are pretty small numbers, but this was standard of care for many decades. The problem, though, is this study was done before we were really using MRI. In the current era, we know that MRI is a much better test looking for brain metastases and monitoring for them. And so when that same study was repeated, but with the use of MRI, what we saw was really that MRI-guided prophylactic cranial radiation did reduce the risk of brain metastases, but there was no difference in survival. In fact, numerically, the survival was better without PCI. And the prophylactic cranial radiation does come at a cost. The cost is the risk of neurocognitive deficits, changes in memory, changes in personality, potentially early onset dementia. So it is a high cost. And so this study really showed there was no survival benefit with prophylactic cranial radiation. The study is being replicated in the US and in Europe through a study called the Maverick trial. And in Europe, the study called the Prima Lung study. Until these results read out, there's still some unclear answers, but largely practice has shifted. And the use of prophylactic cranial radiation for extensive stage small cell has significantly decreased. And in my own practice, it's not something we do very often. What about radiation to the chest? Well, we also noticed that sometimes when we get a response, we would see that original primary cancer grow back. So what if we radiate that up front? And what we saw is that that did improve the chance at survival at a year, but unfortunately it did not meet its primary endpoint of improving overall survival. There is a new study ongoing now in the immunotherapy era to see if radiation to the chest plays a role in advanced small cell lung cancer. What we do know, though, is that for limited stage small cell lung cancer, radiation is very important. About a third of patients will present with limited stage small cell lung cancer confined just right here to the chest. And the standard treatment here would be a combination of chemotherapy and radiation. In a phase 3 trial, I show these numbers really because when we give chemotherapy and radiation together, the chance of response is extremely high, 97%. 40% have a complete response. But if we then look at survival, the chance of 5-year survival with concurrent chemoradiation, only 24%. A response rate of 97%, but only 24% of patients surviving at 5 years. Small cell lung cancer is very responsive. The challenge is in keeping that cancer away and the durability of that response. So the question is, could immunotherapy improve outcomes in this early stage small cell lung cancer? And these are data we saw just a few months ago at ASCO from Dr. David Spiegel. Use of durvalumab another PD-L1 inhibitor, after chemoradiation significantly improved progression-free survival and overall survival. It did increase toxicity. We do see higher rates of pneumonitis, for example, which is something that we have to watch for very carefully. If we look specifically at pneumonitis, about 30% of patients have pneumonitis just after chemo and radiation. 38% had pneumonitis with the addition of immunotherapy. So that is an important side effect we have to watch, but there was a profound improvement in survival. Here we see the hazard ratio of 0.73. We see the increase in 3-year survival rate from 48% to 57%. If we look at the median survival, it goes from 33 months to 56 months. That's a 2-year improvement in median survival. The use of immunotherapy, here only given for 2 years after chemoradiation, has improved survival. This is not yet FDA approved, but this really is our standard of care, and it is in our current guidelines. I think this reflects best practice. At ESMO last week, we saw updates in various groups. What we saw is regardless of what radiation schedule you used, whether you did prophylactic cranial radiation or not, whether you used cisplatin or carboplatin, every subgroup seemed to get comparable benefit with the use of durvalumab. And so this really is our standard. We're hoping that this leads to more cures for early stage small cell lung cancer. Immunotherapy is our new standard. Adding a PD-1 or PD-L1 inhibitor, whether it's advanced stage or early stage, improves survival. And this really is something all patients should be offered. But how do we take that next step? How do we get better? We talked about biomarkers, trying to understand which patients will benefit from which therapy. This is challenging in small cell lung cancer, but important work is being done. But are there any novel agents? And so let's talk about the next generation of agents. There are other immunotherapy drugs, CTLA-4 inhibitors. We use those for non-small cell lung cancer, drugs like tremelimumab or ipilimumab. And what we see in small cell lung cancer, though, is they don't really seem to provide significant benefit here. And there's really no role in an unselected population for CTLA-4 inhibition. TIGIT, this is another molecule that's attracted some attention. We saw some updates in non-small cell lung cancer at ESMO, but the TIGIT study in small cell lung cancer was negative. This was a trial where patients received chemotherapy with immunotherapy and either TIGIT or placebo, and the anti-TIGIT antibody did not improve survival. The numbers completely overlap. And so no benefit in small cell lung cancer with the use of blocking TIGIT. Blocking VEGF, which is an angiogenesis marker. This did seem to show some activity here. Ianlotinib, which is an oral agent that blocks angiogenesis, did show some improvement. Here, the comparison to chemotherapy alone. And so we want to see what the comparison is to chemoimmunotherapy, but this is an area where there's a lot of interest. But we need newer drugs. We need novel agents. And initially, we study them in later line settings, but then we tend to move them a little bit earlier because that's where impact is greatest. Lurbinectedin is a type of chemotherapy. This was derived from a compound isolated from a sea squirt off the coast of Spain in a company that really mines the ocean for novel molecules. What we saw is when we give this agent, lurbinectedin, the chance of response was about 35% overall. This was approved by the FDA in 2020, clearly has activity, and does seem to partner well with immunotherapy. There's a combination of lurbinectedin with pembrolizumab. We see pretty high response rates and the chance to really evoke or draw out those immune responses. And so there are ongoing studies of lurbinectedin in the maintenance setting, but also in the frontline setting. When we look at this study, this is the IMforte trial. Here, patients receive standard chemoimmunotherapy, and then after the chemotherapy is done, they're randomized to just get immunotherapy alone, which is our standard, or immunotherapy plus lurbinectedin. This study hopefully will provide some results later in the coming year. BMS 986012, this is another antibody that tries to evoke immune responses. It targets a molecule, GM1, which really helps to promote more degradation of the cancer cell through different antibody-mediated means. But unfortunately, we saw that there was no improvement in progression-free survival or overall survival. And so we'll continue to look. And really what we think the next wave of agents are these T-cell engagers. And so tarlatamab is now approved by the FDA. This is a bispecific T-cell engager, or what we call a BiTE, that targets DLL3 and CD3. And it's a different mechanism of action. I think it's a very exciting drug. It's now approved and really has emerged as a potential second-line option for patients that need a new treatment. It's a type of immunotherapy, but it's a little different. When we give a drug like atezolizumab or durvalumab, we are blocking the inhibition of our immune cells and allowing our immune cells to be activated and generate an immune response towards the cancer. But allowing the immune cells to do that doesn't mean that they will do that. It can lead a horse to water. can't make it drink. And so our immune cells sometimes will attack the cancer, sometimes they don't. Bispecific T-cell engagers like tarlatamab, they sort of force the issue. And the construct here is shown on the left in that box. And really it is a molecule that's got sort of two arms. One arm will bind to a protein called DLL3. The other will bind to a protein called CD3. DLL3 is a protein that is very commonly expressed in small cell lung cancer. It's on the surface of these cancer cells. We don't know exactly what it's doing. We only know that it's there, but it serves as sort of an anchor. So this molecule, when it's circulating through the blood, if it encounters DLL3, which is more selectively expressed on these cancer cells, now that will bind onto it. The other arm binds to CD3, which is a marker for lymphocytes. And so in the presence of a cancer cell, this tarlatamab drug will bind on one side to the cancer and on the other side to a lymphocyte, push them together, forcing the lymphocyte to interact with that cancer cell and destroying it. Forcing this immune response has been extremely effective, but there are side effects and consequences to doing that. This type of molecule, though, really reflects where we are with drug discovery. It's not isolating natural compounds now, it's creating drugs out of thin air to do exactly what we want them to do. This is the era of synthetic biology. And so that's why our trials are moving so much quicker. Before these drugs even are given to a person, we can estimate how likely they are to work, how likely they are to develop certain side effects. It really is a new era in drug development. And what we've seen with this drug is that it works. In the early phase 1 study, the chance of response was about 23%. And in previously treated small cell lung cancer, that's a pretty high number. The rate of disease control is about 52%. Now, the median progression-free survival at 3.7 months seems modest, but if you look at the duration of response, when patients got that response, how long did it last? And the median number there was over a year. When these drugs work, they work quickly. The median time to response was 1.8 months, so about 6 weeks, we start to see those cancers respond. And the median survival here was just over a year. But the side effects have to do with what this drug does. Because it's forcing the cancer cells to interact with those lymphocytes, we're much more likely to get this immune response. And as the lymphocytes destroy those cancer cells, we can have what's called cytokine release syndrome. That occurs in about 53% of patients. Cytokine release syndrome can be fever, low blood pressure, high heart rate. Sometimes it can be severe and require transfer to an ICU. This is much more likely to occur early on with this treatment. But once we get past a few weeks, it becomes much less likely. This generally tends to be low grade, not too serious, but serious cases have been seen. That's why patients need to be watched pretty closely. As a result, a drug like tarlatamab is typically given in the hospital. And so the way that this drug is approved, on the first dose of the treatment, you would receive the infusion and you would be watched in the hospital for 23 hours, which typically means an overnight stay. You would go home then if there were no problems and come back the next week for the second dose, and you would stay again in that second dose for 23 hours. And this is to see if we develop this cytokine release syndrome, and if we do, to intervene on it so that it doesn't become serious. If there are no problems after that, then we don't have to be admitted, but we do still need to be watched for quite a long time. This is a pretty involved treatment. And so the third infusion, you're watched for about 8 hours. And as time goes on and there are no major problems, the observation period becomes shorter and shorter, but it does require very close observation. Despite the logistics of giving that treatment, the treatment is very exciting because of how well it works. This is the phase 2 study where we really hone in on how well this agent works. In the study, patients were randomized to 2 different doses, the initial dose of 100 milligrams or a lower dose at 10 milligrams. What we saw was 10 milligrams actually was just as good and much less toxic. And the chance of response here was a bit higher than we saw in the other studies at 40%. The majority of these were lasting more than 6 months. These are durable responses shown by this swimmer's plot. We see 40% chance of response. Responses are quick, occurring in about 6 weeks, and they're durable here about 10 months. Survival now just over a year at 15 months. But the side effects have to do with cytokine release syndrome. Now that tends to be early, and you can see here 53% had cytokine release syndrome, but it really was within the first couple of months. Fever, low appetite, change in taste, and fatigue are also common side effects with tarlatamab, but generally in the first 0 to 3 months. Once we get 3 to 12 months, we see it's pretty uncommon and even less common after that first year. Side effects happen early on. We do adjust over time. Now, what about moving this drug a little bit earlier? These were data presented a few weeks ago, the Delphi 303 study looking at giving tarlatamab early on with the use of chemotherapy. This did seem to be safe and was effective, but it's a relatively small study. But as these drugs are developed in later stages, we're going to start moving them up where they can have more impact, where they can increase the likelihood of long-term response. The other class of agents that's being developed are antibody-drug conjugates, and these are very exciting in lung cancer. We're just in the early stages, and we've had some mixed results in non-small cell lung cancer, but the reason why there's still so much excitement is behind the curtain, there's this wave of new antibody-drug conjugates that are extremely exciting and that will make an impact for our patients and our practices in the coming years. They're not all in the clinic. They're not being studied all yet, but this really is the future. The antibody-drug conjugates are a novel class that provides some specificity with the antibody that direct it towards a cancer cell, but also could work perhaps potentially well with immunotherapy. So what I wanted to do is try to explain a little bit about how these drugs work. And so what's drawn here, I apologize, I'm not an artist, but this is my depiction of an antibody-drug conjugate. In gold, we have the antibody portion, and in blue, that little Pac-Man guy would be our payload. So we have an antibody that will bind to a protein. We have a payload that's going to do the work, that's going to destroy the cell, that's going to kill the cell. And then they're connected through something called a linker, which is actually a very important piece of technology. And so as we develop this drug and we deliver it through an IV, it's circulating through the blood, and that antibody is going to be designed to bind to a protein. And that protein is going to be something on the surface. And so if I'm picking a protein, I want a protein that's expressed on every cancer cell, but is not expressed on any normal cell. That would be the perfect target. And I don't know that that target exists, but we want to get as close to it as we can. So I'm looking for a protein, looking for something different that allows me to attack the cancer while leaving the normal cells alone. And so once I find that protein or that antigen that's on the cancer cell, we can design an antibody that will bind to it. So when it's circulating through the bloodstream, when it encounters a normal cell, a normal lung cell, a normal heart cell, a normal blood cell, it leaves it alone because that protein's not there. But as soon as it sees the cancer with this abnormal cancer protein, it'll latch on and bind to it. Right? So that's sort of the perfect scenario where the ADC drug is now binding to that antigen on the cancer cell. When it binds to it, then if I've chosen my protein properly, it'll get sucked into the cell. And so now I've transported this drug from the bloodstream outside the cancer cell into the cancer cell itself. It binds that protein and it gets sucked into the cancer cell. And once that drug is internalized, it's in a different space. It's a different environment. Here's where my linker kicks in, because the linker was holding these things together. And when the linker is intact and the antibody is bound to the payload through the linker, when the molecule is in circulation, it is inactive. The payload doesn't do anything. It's turned off. But once it gets sucked into the cell, the linker is designed to break apart, to dissolve. And when that linker breaks apart inside the cancer cell, all the pieces are broken apart and scattered. And now the payload, which was previously kind of blocked up from working, is now free to exert some effect. The payload was inactive when the drug was circulating in the bloodstream, so it wasn't doing anything. But now that it's released inside the cancer cell, it starts to work. And how does it work? Well, it depends on the payload. But the payload is now circulating on the inside, and if the payload is designed to attack DNA, it'll start to attack the DNA of that cancer cell. But it's not attacking the normal cells around because it's inside the cancer cell. It maybe is something that's blocking mitosis, which is the process of cell division. It'll work there. There's lots of different payloads. The payload is going to exert its effect on the cancer cell once the drug is sucked in. And now it destroys the cancer cell. Once the cancer cell is destroyed, any of those extra payload molecules are free to sort of circulate out and kill all the surrounding cancer cells too. We call that the bystander effect. And that's how we can destroy multiple cancer cells with one drug molecule. It's actually a little more complicated. There are different mechanisms of action that may trigger an immune response as well. It may block signaling. There are different ways that antibody-drug conjugates can work. We're still kind of trying to understand in what patient does it work in which way. But ADCs, antibody-drug conjugates, hold a lot of potential here, and they've shown some early results in non-small cell lung cancer. We've also seen some promise in small cell lung cancer. And so sacituzumab govitecan is binding to a molecule called TROP2 that's highly expressed on small cell lung cancer cells. And in this study presented a few weeks ago, we saw the chance of response 42%, the median duration of response about 5 months, but survival out over a year. There are different side effects. The side effects have to do with that payload, because once it's released, it can have an effect on our body. Here we see diarrhea, fatigue, and neutropenia as the main side effects. A different antibody-drug conjugate, this one called ABBV-706, just letters and numbers right now. When we see a license plate name, that means the drug is still pretty early in development. But here we see a CT scan on the right showing liver metastases melting away. We see a waterfall plot here on the left showing that in nearly all patients, the cancer gets smaller. The chance of actual deep response, about 60%. Still immature early studies, but hopefully we'll have a response on this exciting drug. There are side effects here, primarily hematologic, so affecting the blood count, though you can see fatigue, nausea, and alopecia with these agents as well. Ifinatamab deruxtecan, or IDXD, is another one that's targeting B7H3. These are all proteins that are on the outside of the cancer cell, but not so frequently outside of normal cells. By using that, we can gain entry into the cancer cell and destroy it. Here, what we see is when we give ifinatamab deruxtecan, we see the chance of response at the right dose is about 55%, which is a very high response rate. The rate of disease control was 91%. There were side effects. Certainly, we see high rates of nausea. We see the chance of lower appetite, of lowering blood counts as well. And there was a risk of something called pneumonitis, which is an inflammation within the lungs. So if we think of small cell lung cancer, our standard of care really is the use of immunotherapy, either atezolizumab or durvalumab with platinum etoposide, and that improves survival. But it's not that it improves survival a little bit for everybody. What this does is it gives us the potential for long-term survival for a subset of patients. But today, I don't know who that subset is. And so we give immunotherapy to everyone, because it would be a shame if someone was destined to be a long-term survivor to deprive them of that opportunity. And so everyone receives immunotherapy with chemotherapy in the hopes that we're in that 12% that are alive at 5 years and doing well. If we're not in that group, there are other newer options. Biomarkers are important, but we have newer drugs such as T-cell engagers, antibody-drug conjugates, and the best option really is a clinical trial. Clinical trials are taxing, they are hard, there's much more involved in a clinical trial. This is where we have the best drugs. In a case where the best standard treatment is not nearly good enough, which is how I would describe small cell lung cancer, trials really are our best path forward. And so we really want to pursue trials when we can. And so that is the last slide here. I think we have 10 minutes for Q&A, and I'll be happy to answer any questions. And again, thanks for having me today.
Thank you, Dr. Liu. That was an excellent overview of kind of where we've been with small cell and the promise that we're now seeing in this space. And I think, as you indicated, it's an incredibly hopeful time, but we still have a lot of work to do. And so one of your last comments was on the importance, as we know, for all lung cancer, of early detection. And I'm curious, because we are seeing, as with non-small cell lung cancer, limited stage versus extensive stage, we have better outcomes. So how can we work to improve early detection for small cell? That's something that maybe we haven't typically seen, because it tends to progress faster, and unfortunately we tend to catch the majority of patients at later stages. So what are your thoughts on how we can further improve early detection and screening for small cell? Is it the same? Do we need different approaches for that compared to non-small cell?
I think we do need different approaches. And so I think you hit the nail on the head, Amy. Small cell lung cancer is generally one that grows fairly quickly and doesn't have this slower natural history that would make it a little more susceptible to screening. We do pick up small cell lung cancer on screening CT scans. And so we're very strong advocates for lung cancer screening for patients with a smoking history. We will pick up some earlier small cell lung cancer there. And as you mentioned, it's important to pick these up earlier, where we have more options, where a chance for long-term survival is much better. Our outcomes are better if we pick these cancers up earlier. But for the majority of small cell lung cancer, they are built for speed, not for slow growth. And so they'll often evade those windows of screening. We do think there's promise in blood-based detection. So there are certain signatures of small cell lung cancer where we can use liquid biopsy, blood-based tests to identify some of these changes that could be suggestive of early lung cancer. These are being involved in sort of larger platforms that aren't designed just for small cell lung cancer, designed for many different cancers. We're still pretty far away from that. A test like that has to be very specific, but also pretty sensitive. And so we don't quite have the technology that is where the field is going. I think the big points today, 2024, CT screening for lung cancer, absolutely. Smoking cessation and intervention, because this is potentially for some patients the cancer we could prevent, but also really just an awareness. We still see a lot of nihilism around lung cancer overall, but I think especially in small cell lung cancer. And so there are many cases where patients will be deemed too frail or too elderly to receive treatment. We know that's not the case at all for small cell lung cancer, that with treatment, patients' lives can be much better. And with some of the newer treatments out there, survival has a chance to be really prolonged as well. So tackling that nihilism, understanding that if there is something wrong, if we do see abnormalities, we need to find out what it is, because now in 2024, there's a lot we can do about it.
You talked about I guess the geography of small cell lung cancer. I'm originally from the Southeast. I currently live in the Midwest, and we know there is this association with the tobacco history, which, kind of aligns with that tobacco belt that we think about in the U.S. And so I'm curious, and we know that 85% of patients with cancer get treated in their community setting. They prefer to be closer to home. So I'm curious, with some of these newer modalities that are coming online, like tarlatamab that you mentioned, where it has to be delivered in a hospital setting, how are we seeing those being deployed in community settings? Are we there yet? Do you see this being a deterrent for patients when they may have to think about traveling to a center where they can get that, compared to being closer to home? So can you talk a little bit about how widespread these treatments currently are? Is it academic primarily versus community? Is it widely accessible, and where are we with that?
I think this is a really important point. I'm glad you brought it up, because the truth is there are some disparities in access to a lot of these newer agents. Tarlatamab is a great example, where it requires an inpatient observation 2 weeks in a row, and a little bit of uncertainty as to how long you're going to be in the hospital. It's really difficult for some patients to have that uncertainty or to travel to an academic center to do that. So there are studies going on now that are looking at decreasing the observation. This is an early drug. It's sort of a new molecule for us in lung cancer. So we want to be safe first and foremost. But we're starting to toy around with maybe observing a little bit shorter, and we need to make sure that it's safe to do that. We're looking at different strategies to try to reduce the risk or identify people that are at greater risk. And so my hope is that in the coming year, we'll start to see that requirement go down a little bit, make this a little more outpatient, a little bit easier. The burden will still be there, though, and sometimes patients will need to travel quite a distance. What we've done here at Georgetown, and I think others will as well, is a lot of times we'll start the treatment here where the risk is greatest. And once we get a few doses in where the risk significantly drops, then we can slide the treatment over to a local community physician where maybe the risk and expertise doesn't require that inpatient or academic setting. And so it's sort of a hybrid approach where we can start treatment, make sure there's no big side effects, make any modifications we need to. And once we're at a point where the treatment is pretty smooth, to allow that to be delivered closer to home, which is a little more convenient to patients. Because the point of all these treatments is to have patients at home, is to have them living their lives and doing what's important to them, not to be 40 miles away at an academic hospital. We want people where their lives are. So if we can slide those over earlier, I think that'll be where the future is. In the meantime, if there are newer molecules out there and maybe only available through clinical trials, while travel can be difficult, it's not insurmountable. And there are a couple different perspectives to keep in mind. On one hand, a lot of doctors won't offer clinical trials to patients, saying, well, this is too far for you, making that assumption. I think that's dangerous because some patients are able to do that. And some patients will say, well, frankly, logistically, it's difficult for us to go there. It can be expensive, finding someone to drive and so forth. But a lot of trials sort of open their eyes to those inequities and are providing travel, reimbursing travel, some hiring cars to sort of help people make that. We want to try to make an even playing field. We want to try to reduce all the barriers that we can. And, hats off to a lot of the sponsors that have really identified ways to do that. So if you don't think a trial is right for you, make sure you talk to your doctor about that. Go to clinicaltrials.gov. The trials are listed there. Go to LUNGevity, go to different resources and really try to identify, is a trial right for me? it may seem like an insurmountable task, but we're here to help, and it really is the best treatment. There are a lot of resources I think people aren't totally aware of.
That's a very thoughtful response. Thank you for that. So we heard Dr. Peters talk this morning on kind of the era of precision medicine for lung cancer with, a growing list of targetable mutations. And so one of the challenges that we see in that situation is that we are encountering more situations where somebody starts out with non-small cell lung cancer, they go on to targeted therapy, they develop a resistance, and so their non-small cell can turn into or transform into small cell. And that's something that we didn't really delve into in your presentation, but it's something that is very much on top of the mind of our listeners. So I want to hear your thoughts on this growing incidence of small cell transformation, and is it the same as de novo small cell? Is it different? How do we approach it? And so that's the question. Can you talk a little bit about transformed small cell?
It's a great question. It's underdiagnosed. And so you can only really see this through a tissue biopsy. And so there are some studies saying 15, 20%, even higher will undergo small cell transformation, but will be misled by liquid biopsy or blood-based tests. Liquid biopsy is very helpful. We do it all the time in patients whose cancer seem to be growing through targeted therapies. It's easy. It's not so invasive. It's very quick. Biopsies are more risky. They're more challenging. They require a little more coordination to do. No one likes having a biopsy done, but a biopsy is really the only way to really detect small cell transformation. That's why I think it's underdiagnosed. There are cases where we've done a blood-based test and we've seen something different, a BRAF mutation, a new mutation that we know can cause resistance. But in those cases, we'll also do a biopsy and I'll also see small cell lung cancer. And so we really only know when a biopsy is done. The reality is sometimes it's just not possible to do a biopsy. I understand that. Sometimes it's just not possible. When it is, I strongly advocate for it, because if we see small cell, we treat that differently. That's not going to respond to these targeted agents. We don't really know the ideal way to treat it, though. We're still trying to understand exactly why it happens. We do know there are some things that increase the risk of transformation to small cell lung cancer if there are certain mutations present from the beginning in genes like P53 and RB1. It significantly increases the likelihood that eventually we'll see a small cell transformation. It doesn't guarantee that we will, though. And there's cases where it can happen without those mutations as well. So we're still trying to understand why it happens, because that'll help us better treat that. Right now, our treatment is largely based on sort of de novo, original small cell lung cancer, but the studies really haven't been done. In my experience, we do see responses to the same chemotherapy backbones of platinum and etoposide. But the big question has to do with what role does immunotherapy play? In a tumor that has an EGFR mutation or an ALK fusion or a RET fusion, we know that immunotherapy is not really too active. We don't give immunotherapy up front, and we try to avoid immunotherapy given with or before targeted therapy, because it makes the targeted therapy much more dangerous. In small cell lung cancer, immunotherapy really is part of our standard of care. It can lead to long-term survival. But what if our cancer sort of bridges those two? What if our cancer has aspects of non-small cell, but also aspects of small cell? On one hand, you want to give immunotherapy because of the small cell portion, but at the same time, if you do that, you can't give targeted therapy for the non-small cell portion because those two paths don't really intersect. So most of us will omit the immunotherapy, give chemotherapy, and continue the targeted therapy. But the reality, Amy, is I don't know if that's the right strategy. I don't know how much either component is doing because it hasn't really been studied. When EGFR transforms to small cell lung cancer, when any targeted subgroup transforms to small cell lung cancer, often we find them being ineligible for any trials. They don't meet the criteria for the small cell studies or for the EGFR studies, and we're sort of in limbo, and the field hasn't moved a lot. We know it exists. We know what we often do, but we don't know what the best thing is to do. That's finally starting to change. And over the past year, we're starting to see more studies focused on small cell lung cancer that include small cell transformed from EGFR. And I think a lot of the new antibody-drug conjugates are effective there. I'm very interested to see how some of the T-cell engagers could work in that setting as well. So there are several studies that allow transformed small cell lung cancer. Again, another setting where trials are more important, I think, to really get the best possible option out there. But we haven't figured out exactly why it happens, which is the first step to preventing it from happening. But there are a lot of really smart people working on fixing that right now, some of them through the support through LUNGevity.
Well, thank you for that. Yeah, I mean, so that's an incredibly important topic to our community. You talked a little bit about efforts to identify biomarkers for small cell and how we're just not quite there yet. And so I'm going to ask you to put on your, prognostication hat and look into the crystal ball and say, how far out do you think we are from really having actionable biomarkers for small cells, similar to what we currently appreciate in the non-small cell space?
Amy, I think you know more than most, and I tend to be pretty optimistic. And so I think we're closer than people realize. We're not there yet. And while these original findings being done by our colleagues like Charlie Rudin and Laura Byers really show different subsets, work that Chaparna Sen's done, showing there are unique subsets in small cell lung cancer that can maybe predict biologic behavior. It hasn't translated to people yet. There's a big leap that we need to make there, big processes like plasticity, like tumors moving from one to another, like heterogeneity, because tumors often will have a little bit of multiple different types of subsets. But we're making some really key advances that will allow us, I think, to control those processes more. And once we do that, we can really leverage those characteristics more. So we're not there today, but my hope is, within the next couple of years, I think we will have some early biomarkers to guide therapy.
That's great. You use this word plasticity, and that just means the ability of the tumor to kind of change, And so, one question that comes up, and I've heard before, is, since we have so many options in the non-small cell space, can we take a small cell lung cancer and, use those plasticity pathways and kind of transform it into a non-small cell lung cancer where we can, throw different things at it and maybe have more success? So, rather than going from non-small cell to small cell, can we do the reverse? And does that show treatment potential for those who have small cell?
Yeah, I love that idea. And something that we've toyed around with a little bit of time. Can we control the differentiation? Can we force these cancers to become a little more differentiated where they might be responsive? Those strategies haven't really worked out. It's just so much more complex when we go from the laboratory into an actual patient where there's so many different things happening. So I do think that understanding the process, when we think of these basic science advances, when we think of studies that are really looking just at a cellular level, they're so important because if we can fully understand the pathway, then we can maybe manipulate it. Then we can maybe sort of leverage those changes. And so understanding really is the key. We don't want to just guess at a treatment and see if it works. We want there to be some basis. And so it's found in understanding, and that really takes a long time. One of the things that sort of, I think, hurt small cell lung cancer that we didn't see with non-small cell is we didn't have really the right specimens. For non-small cell lung cancer, we'll often get sort of tumor tissue to run these studies from surgeries, where we remove a big piece of tumor, we take it to the laboratory, and we're able to develop these models to try to study different strategies. In small cell lung cancer, we don't usually do surgery. And so when we do surgery, it's at a very early type of small cell lung cancer that honestly is probably a different cancer. And so these early stage small cell lung cancers that we remove, we can study those a lot more. We can develop those models because the tissue is there. But does that reflect what's happening in most of our patients? Probably not. And historically, we weren't able to get a lot of tumor specimens for study because small cell lung cancer was so quick. It's a central tumor. We often had very small biopsies, and you don't need a lot of tissue to make the diagnosis. So we said, well, this is a tumor that's kind of hard to biopsy. Let me just start chemo first. And when we start chemo, the tumor shrinks very quickly. When it comes back, it's a little bit different. So the models we have to study small cell lung cancer were not representative. They were flawed.
Mhm.
Now we're starting to see some changes where we push back on the fact that we can't get biopsies. It can be more challenging to get the biopsies as part of these studies, but it's not impossible. And we really do think it's important and worthwhile. And so we are seeing more and more studies where we're having actual accurate representative models based on really more early biopsies and available tissue specimens. I think it's really important in studying small cell lung cancer, and we're starting to see that change now.
That's an absolutely great point. Well, I know we're at time, so I just want to thank you for your incredibly insightful and helpful overview of small cell lung cancer, the treatments that we've had, and where we're going in the field. And it's always a pleasure to be with you. And thank you for your leadership and your commitment to the lung cancer community. Thanks again, Dr. Liu.
Oh, it's a privilege. Thank you for having me here, and I look forward to following along the rest of the day.
Take care.